you, sir. Thank you, sir.
Okay, and we go ahead.
Shall we wait or should we start?
No issue, sir.
Uh,
I think 12
meeting
people are
room.
waiting. So after you,
Meeting room.
Waiting
after
room
the join.
disable ಮಾಡಿದ್ರ Nindra?
From here, meeting room disable even from even lesson. Meeting room disable from here.
Controls ಅಲ್ಲಿ ಇರುತ್ತೆ ಇದು.
Meeting room disable ಮಾಡೋಣ.
Waiting room, waiting.
Admit ಆಗತ್ತೆ.
Admit all.
Admit every time admit. We have 27 participants now. Sandeep, can you share your screen? Sandeep?
Huh?
Sandeep screen share ಮಾಡಿ.
Okay, okay.
Yes, just check by the time you.
Yes, sir. Yes, sir.
Okay, we start, sir.
Yes, sir.
Good evening, everyone. Am I audible? Sandeep?
Yes, sir. Yes, sir. You are audible, sir.
Yes, sir. Good evening, everyone. Welcome to this IAMM-KC masterclass. Today, we are having a very important topic, the NHSN 2025 guidelines for diagnosis of healthcare-associated infections. We welcome on behalf of IAMM-KC, I welcome all the participants for this session. And today we have one of the very eminent, very good speaker, young, dynamic, very good friend of me, Dr. Sandeep T. A very known person in the field of infectious disease. Dr. Sandeep T, presently working as associate professor at BGS Medical College, Nayamangala in Bangalore. Done his MD microbiology from Ambedkar Medical College and was previously working at MS Ramaya Medical College. Then recently shifted to BGS Global Medical BGS Medical College, Nayamangala, Bangalore. Dr. Sandeep, along with MD microbiology, he's also done his master's in medical sciences, infectious disease from the prestigious University of Edinburgh, United Kingdom, and is closely associated with working as a hospital infection control officer previously in MS Ramaya and now in BGS Medical College Hospital, Nelamangala. He is a esteemed member of various national and international societies. One of the, I have to say that he is one of the member for IDSA, Indian Infectious Disease Society of America also. So he has got vast experience in the field of infectious diseases and especially healthcare associated infections. And Sandeep has got more than around 15 publications to his name in various national and international journals and has been invited speaker for various CMEs and national conferences. I have heard to Sandeep in several CMEs and really impressed with the way Sandeep handles the infectious diseases and healthcare associated infections. So with this background, I personally wanted Sandeep to handle this for the sake of postgraduates. So the postgraduates will be benefited by the Sandeep's knowledge and the inputs. Any queries you have, you can put up the questions in the chat box. We will take up the questions at the end. Okay. Now the platform is over to you, Dr. Sandeep.
Thank you. Thank you so much, sir, for that wonderful introduction. I thank IAMM-KC members, board members, for the executive committee members for giving me permission to share my knowledge to in this forum. Am I audible? Is my screen visible to everybody?
You are audible.
May I request other participants to kindly mute their.
Okay. Shall we start with the topic? So first of all, let's see what is, before I start off with the topic, a few things what I wanted to tell you is, one is, I'm going to just give you an overview of healthcare associated infection. There are, there are guidelines where we use those guidelines to diagnose healthcare associated infection. I'm not going to teach you everything about healthcare associated infection. It's just an eye opener, you can call it. But I will give you the resources for further study. I think you can read up on that and become experts. At any point of time, you have any doubts or anything, you can stop me. I would like it to be more interactive with the permission of course, yeah, IAMM-KC executive members. Shall we go ahead then?
Please go ahead, sir.
It changes. Yeah. Okay. What I would do is I'll just stop my video so that there is no lag in the presentation. During the question answer session, I will switch on my video. Now, first, for the benefit of freshers, for the benefit of new people in the field of microbiology, I've just put a definition of healthcare associated infections. What do you mean, or what do we mean by healthcare associated infections? These are infections which are acquired, or the patient acquires this infection while receiving care in a healthcare facility. Healthcare facility means everything. It's a big umbrella word. Clinics come under that, laboratories come under that, hospitals, these polyclinics, nursing homes, all of them are considered to be healthcare facility, including physiotherapy, clinics. So any infection got or acquired while receiving care in such healthcare facility is called healthcare associated infections. But what we have to keep in mind is that these infections are neither present when the patient is coming to the healthcare facility, or it should not be the person is incubating that infection at the time of admission. Usually, such infections, that healthcare associated infections, appear after 48 hours of admission. Okay, that is the magic number that we have fixed, that any infections which happen after 48 hours of admission, we consider that to be a healthcare associated infection. Of course, it is up to us to prove that it is exactly or it's actually a healthcare associated infection. But for screening purposes or surveillance purposes, this number of 48 hours is taken as the magic number. There are some cases or some infections which are seen after the patient gets discharged, but it can be linked to the hospital stay. Okay, these are the surgery related infections, surgical site infections. They can be seen
Dr.
after the patient
Sandeep,
goes home.
your
Yeah.
slides are not going, maybe.
No, I have not changed. I have not changed.
Yes, thank you.
Yeah. So the patient, after the patient gets discharged, you can see these infections, but it is linked to the hospital stay. Means to say the patient was, admitted for some surgery. Surgery was done and patient was sent back home, but then the infection comes up. So those are also considered as healthcare associated infection. Now, for such infections, there are a huge list, but what commonly we look at it is COTI, VAP, SSI, CLAPSI. Okay, can any of you expand these short forms? Have you heard of these short forms? Can you expand them, please?
OT is catheter-associated urinary tract infection.
Okay, VAP,
Ventilator-associated pneumonia.
very nice. And SSI,
Surgical site infection.
super. CLAPSI,
Central line associated bloodstream infection.
very nice. So just to repeat, COTI is catheter associated urinary tract infection. VAP is ventilator associated pneumonia. SSI is surgical site infection, and CLAPSI is central line associated bloodstream infection. Okay. So these are the common ones. Traditionally, we have been following it up, diagnosing and all that. But as we see practically, okay, in the hospital, there's a lot of overlap. There's a lot of gray area. Okay, while actually putting or diagnosing VAP or SSI, even for that matter, CLAPSI also. Okay, so there are some other definitions or some other infections also related to these classical four HAIs. As we go through the discussion, you will understand others. So first, what we will do is this is just an introduction for the healthcare associated infection. Now coming to how do we diagnose these infections? There was a lot of confusions, lot of deliberations, you can call discussions on how to do all these, how to diagnose basically these infections. But commonly there are three organizations, three associations that we look for, we look up to for their guidance in diagnosing these infections. The most commonly and widely used guidelines is from the NHSN, that is the National Healthcare Safety Network, which is a part of CDC, okay, the US. So they give out guidelines which are commonly used across the world. Probably small changes here and there when it comes to European Center for Disease Prevention Control and NHS UK also. Okay, basically they follow the same guidelines, but they have changed or a little bit, changed for their own country. Okay, depending on what they see and how they report basically. But NHSN guidelines is a very good guidelines to start off with. Okay, the only I would say, I wouldn't say problem, but the only thing that we have to keep in mind is that NHSN guidelines change every year, or it is updated. I wouldn't say change. Better word to tell is update. Okay, so they are updated every year. So the guidelines what I'm describing today is 2025 guidelines for this year. In January, they're going to come up with the 2026 guidelines. There won't be major change as such. Okay, small changes are expected. So whatever guidelines that we are going to discuss today, just keep that in mind. And I want you to get updated in January when the new guidelines come up. So how I'm going to go about this discussion is that we'll start off with a case and see how we can diagnose. The guidelines are very, I mean, for me, at least, guidelines are very boring to learn because it's just facts and I can keep going. I can just talk and finish the talk, but learning becomes interesting when it is related to some case that we have seen in our hospitals. So first, let's start off with this case. A 50-year-old man who was brought to the emergency department with a weakness in upper, left upper and lower limbs. Okay, you can guess that he is having a stroke. The nursing staff accessed the veins.
Sandeep, slides are not moving.
Can you see the case one slide?
No. The first your title slide is in still.
I don't know. Okay, once again. It says screen sharing is paused. How do I? It says paused here, so I don't know how do I reactivate it. I mean, I don't know. Okay, now. The moment I put it to slide share mode, it is going to paused. Hello, sir. Hello. Is it visible now? Can anyone hear me?
Go ahead, Sandeep.
Sir, the moment I put it to slide share in the this one, it's going off to
You can continue like
paused.
this.
No, if I put it in the slideshow mode, it's going to paused Screen
And you can
sharing. Like this only I'll continue?
you continue like this
Okay, fine.
because
Yeah. Okay, this is the case one that I was talking about. A 50-year-old man was brought to the emergency department with weakness in left upper and lower limbs. Nursing staff access veins and catheterize the patient. Neurology resident shifts the patient to ICU for thrombolysis after radiologically confirming that it's a thrombotic stroke. On day 2, the patient has fever. Routine cultures were sent. Urine culture grew E. coli. Of course, it was a significant count, so they had reported on that. Few pus cells on gram stain. Now, how many of you think that this can be a COTI? Yes, can you put it up in the chat box or raise your hands, or you can do something. How many of you think that it can be COTI? Not COTI, not COTI. Okay. Now, how did you decide that it is not COTI? So that is the question. So for that, we have to go back to our guidelines and let's go to the definition of UTI. What is a urinary tract infection? Fine. So when you look at urinary tract infection, it's classified into symptomatic and asymptomatic. Okay, they've given these short forms: SUTI, that is symptomatic UTI, and asymptomatic ABUTI. So this is the first classification. So if you look at this one, more stress is given on clinical aspects. That is, the patient should complain of some kind of symptoms related to urinary tract infection. Then you go ahead and see if he's having, a significant bacteriuria and identify what bacteria it is. Anyway, first classification is symptomatic or asymptomatic. Under the symptomatic, you have catheter associated, non-catheter associated. It can be in adults or in pediatrics. So all these, whatever I've put it in the bracket, each one, there is a sub guideline, you can call it, within that NHSN UTI guidelines. I put up this flowchart only to impress upon the fact that urinary tract infection has to be a clinical diagnosis and then go to microbiology. Most of the aspects in these guidelines, that is NHSN guidelines, if you look at it, they stress more on the clinical aspect. So there has to be some kind of clinical diagnosis before you actually confirm the same infection, using microbiological investigations. So what does this NHSN guideline for COTI say? Okay, so COTI is catheter associated urinary tract infection. For for you to diagnose COTI, the first and foremost is that there should be an indwelling urinary catheter that has been in place for more than 2 consecutive days in an inpatient location on the date of the event. The date of the event is nothing but the day the patient is having, say, fever or some kind of symptom related to UTI. So before that, the patient should have had the urinary catheter for at least 2 consecutive days. And one more thing, what they say here is that it is nothing to do with your 24-hour clock or time, nothing like that. If the catheter has been placed at any point of time today, then it's taken as day 1. Okay, so tomorrow is day 2, And on the third day, okay, it is just calendar days. We don't consider whether the patient has, the catheter was placed at 10 o'clock in the morning, night 10 o'clock, or something like that, nothing like that. So you just take that if whenever the date of catheter placement is there, you take that as day one and then go further. So that is the baseline assumption that is done for all the guidelines, for all the things that is described in the guidelines. So the catheter should be there for more than 2 consecutive days. And then he has to have at least one of the following signs and symptoms. That is, fever should be there, more than 38 degrees centigrade, suprapubic tenderness, costovertebral angle pain or tenderness. So all of us do understand that if the catheter is there in place, patient might not complain of dysuria, frequency, all that, correct? So be very aware that you are not supposed to ask these questions also, because it is irrelevant. Those dysuria and frequency, all that is for non-COTY, when the catheter is not in place. So when the catheter is there, you look for suprapubic tenderness and costovertebral angle pain or tenderness, of course, along with fever. So once these two criteria are satisfied, then you go to the culture report. In the culture report, what are we looking for? We are looking for an organism, whether it is grown, and what is a count. Okay, it should be a significant bacteriuria, 10 power greater than or equal to 10 power 5. Okay, previously there was a lot of guidelines which came up. Some there was another arbitrary number of 10 power 3, 10 power 2, and all those numbers. But now, even if it is COTY, the same significant bacteriuria number that we have been learning for other say non-COTY is the same. So it's 10 power 5 colony forming units per ml. And one more thing is, there can be two organisms. Okay, at least one of the organisms should be in this range of greater than 10 power 5 CFU per ml. Okay, if there are more than two species of organism which has been isolated, then we don't consider that as significant. Fine. So up to two species of the organism, at least one greater than 10 power 5 is what is to be taken. So if all these three criteria have been satisfied, then you go ahead and diagnose this case as COTY. So in our case, if you I'll just go back to the case here. The patient had fever only on day 2. Okay, so it doesn't qualify for the first criteria itself. Okay, and there's a lot of practice that is regarding this routine cultures. Okay, the moment patient has fever, immediately all cultures are sent, pan cultures, I don't know whatever they call, blood descent, urine descent, sputum available, that also they would send. Okay, so if you start sending all samples, obviously something or the other will keep growing in that. But then what is important, what is not important, that has to be taken into consideration before treatment starts, or rather antibiotic therapy starts. Okay, so moving on, how do we record and report COTY? This is one, usually we used to calculate rate of COTY, right? Number of COTY divided by number of catheter days. That is the third thing here that you can see here. Number of COTY that we have diagnosed divided by number of catheter days into 1000 was a traditional way of calculating things, and many places still continue to do this. But now we have to shift to this method of recording, that is standardized infection ratio, wherein it's something like that chi-square test. Okay, what we do, observed by expected. So what is the observed COTY, number of COTY, and expected number of COTY? We divide that and then see if it is greater than 1, then it indicates high levels of COTY in that particular hospital. And then the need for infection control practices should be strengthened in that place. Okay, so the next question that is asked generally is, where do we get this number of expected COTI? In Western countries, of course, US, UK, and European, they have a very good, robust reporting system wherein they get a national average, local average, and that would be taken as the expected COTI. But here, unfortunately, in India, it's very, we don't have a robust reporting, national reporting system for HAI. So we don't get this expected COTI numbers so easily. So generally what we do is we just take the Western numbers and try to see if we match that. Okay. Or you can refer to some studies which have been conducted in that local area to say what is a percentage of COTI that is seen. Okay. So that is one, that is the that is how we are going to record COTI. Then there is something called standardized utilization ratio. This we can, this is another way. It's kind of a surrogate marker for COTI. Here we are just going to calculate the catheter days. What is the observed catheter days and expected catheter days? Again, here the problem comes with the denominator where we don't know the expected catheter days most of the time. If there are any studies, good studies with a large number of sample size, then probably we can consider that. But this problem is not there in other countries where they have a reporting system. Device utilization ratios also can be calculated to see if the catheters are being used for unnecessary number of days or something like that. So these are the ratios and indices, okay, indices that is recorded and used for the purpose of reporting. Now coming to prevention strategies, I think all of you are experts in this. I'm just revising or reminding you what is to be done, that's all. Nothing new in this. Of course, training is the first thing that we have to do. What should we train on? First is whether the patient needs a catheter or not. Okay, most of the time what happens, we during ICU rounds, the clinical faculty, the consultant looks at many things, but forgets to see whether the patient really requires a catheter or not. Okay, there should be a daily assessment. Every day, the consultant should ask, does this patient need a catheter or not? Okay, if yes, then continue. If no, then immediately remove the catheter. That is the best way to stop or COTI. Okay, then of course, insertion bundle. We all know that there is something called bundle care, which is a set of steps that is followed for prevention of infection. So there is something called insertion bundle where you take care of the asepsis, how you insert the catheter, how you hold it, what you put on the catheter, all that is there. Okay, so that is the insertion bundle. Then catheter care bundle. After the catheter is inserted, then every day what is to be taken care, where, how to clean, where to touch, where not to touch, all that is under this catheter care bundle. Of course, hand hygiene, as always. The best way to prevent all infections is hand hygiene. It works well for UTI, COTI also. Okay. So moving on. So let's go back to our case again. So the same patient who was in the ICU, he was put on ventilator on day 3. Okay, in view of dropping saturation. So on day 5, what happened? New onset of fever started. Okay, so everybody is very anxious now. So day 3, there was no fever, but then day 5, again fever started. Nurse complains that ET secretions have increased, requiring frequent suctioning. Clinical examination reveals crepitations on the right lower zones. Chest X-ray was taken. it showed a non-homogeneous haziness. Okay, so if you don't consider this additional information, okay, leave it like that. But with this history, okay, with this description, are you happy or are you satisfied that it can be a ventilator associated pneumonia? Yes, so many of them are telling yes, yes, yes. Now, how did you come to that conclusion that it is ventilator associated pneumonia? I wanted some people to say no, so that there would be some kind of a discussion, right? So, how do I say that there is VAP or not? Now, coming to that, there is a guideline. Again, it's a clinical guideline where, we, one second, yes, the CPIS. Okay, so this is a scoring that is given for respiratory tract infections, especially for patients who are on ventilator. Fine. So first of all, we have to diagnose that the patient is having pneumonia. Okay, so for that, this is very useful. Again, if you look at it, can you see microbiology anywhere here? The last slide. Got it? So the beginning few parameters are mostly clinical parameters. Why this kind of discrimination, you can ask me? But then if you look at it practically, microbiology culture takes time, right? All of us know that it takes time, and the reports from microbiology department takes time. The only thing is, if the patient is already started with some kind of healthcare associated infection, the main aim is to treat and prevent it, right? So first of all, the patient should not suffer. So first, the treatment has to be started as early as possible. Okay, we can't wait for microbiological report to start treatment. So that is why, that is the main reason why clinical criteria is given more importance as compared to microbiological investigations. But whatever said and done, unless there is a microbiological report, the confirmation of that infection or the organism that is causing this infection is not clear. So it's more of what do you say, microbiological report comes into play for making a personalized treatment protocol for that patient, and the clinical criteria is helpful in starting an empirical treatment for the patient. So here, what we have to look for is tracheal secretions, chest radiograph, temperature, and PaO2 by FiO2. Okay, that ratio and white cell count. So here, why I'm telling you all these things, all of us have to know about this clinical criteria also. Okay, most of the time, when we sit for RCA, okay, the root cause analysis, as a infection control officer, as a microbiology consultant in a hospital, you will be called for meetings wherein they discuss on whether it was a HAI or not, whether take an action or not. All that discussion happens, and root cause analysis, what went wrong, why did the patient end up having HAI, all this discussion happens. So in that discussion, for you to participate, you should know about all these criteria. And one more thing, what I want to tell is, comparatively, with the clinical colleagues of us, microbiology consultants have a little more time, okay, uh, to spare with the patient or patient file or patient attenders, and can be a very good, can develop the very good skill to diagnose these HAIs. So I think we should learn about these clinical criteria and look for all these things before we actually label the patient as having VAP. So that is why in this slide I had put some additional information. PaO2 by FiO2 greater than 240 WBC of 22,000. That is there here. Okay. So if you look at the points, our patient is having lot of 2 points, right? There is a localized new infiltrate. Okay. Then there was tracheal secretions. The nurse has told that there is a lot of secretions. And okay. So the microbiology culture is there. Then you have the white blood cell count also going up. So with all this, then you decide that the CPIA score is high, and then you decide that the patient is having pneumonia, probably VAP. So let's go to the NHSN guideline for VAP. So here what happens? There are two categories, two sets of features that you have to look for. Of the first thing you have to look for, at least one of the following should be present. That is fever, leukopenia or leukocytosis. For adults greater than 70 years old, altered mental status with no other recognized cause can also be taken as one of the symptoms. So one of this should be present, plus two of the following. Means to say that if one line has more than one symptom, it is considered as one itself. You can't tell dyspnea is one, tachypnea is another, cough is another. It's not like that. Okay, dyspnea, tachypnea, and cough, everything put together as one criteria or one symptom. Okay, so there should be two of the following. Okay, from separate lines. Okay, they've clarified that. So new onset of purulent sputum or change in character of sputum, increased respiratory secretions, increased suctioning requirements. The same thing that the nurse has informed. Then the patient should have dyspnea, tachypnea or new onset worsening cough, rales, bronchial breath sounds, worsening gas exchange. Okay, so this is the one which we are going to look for, PaO2 over FiO2, whether that ratio is less than or equal to 240 or greater than that. So after all these things, then only you're going to tell that the patient is going to have VAP. Then what about microbiological criteria? Here we get lot of samples. Different samples can be obtained. Okay, so we need to have this table at the lab where we are going to report. So if it is a lung tissue that is being sent, then 10 power 4. So you have to do a quantitative or at least a semi-quantitative cultures of that lung tissue to find out if the organism number is 10 power 4 per gram of tissue. Suppose you get some bronchoscopically obtained specimen like ball, then protected ball and protected specimen brushing, all this. If these are obtained or if these are sent to the lab, then the numbers are shown here as 10 power 4 and 10 power 3. There are non-bronchoscopically obtained or blind specimens like BAL and PSB, which are which can be sent, but not under the not using bronchoscope basically. Then the criteria, the number is 10 power 4 or 10 power 3. The last one, that is endotracheal aspirate. So this is the one which we commonly see in microbiology laboratories, and for that the count is 10 power 5. So if you look at it, the order of importance, the lung tissue is given the maximum importance, and then endotracheal the least. But still, endotracheal aspirate is the commonest sample that we get. So that is 10 power 5 coliforming units is what we should be looking for. Most of the places, if they are not doing a semi-quantitative streaking on the plates, then it's very difficult to count the colonies and give a proper report. When you look at the pathogenesis of VAP, it doesn't happen overnight. Okay, so it takes a lot of time for the bacteria to infect or go to the lungs basically. So there might be colonization before the person goes into VAP, there are a lot of events that happen. So there might be just colonization of the bacteria initially, then only invasion. Okay, so we have to be a little careful in not over reporting whatever grows on ET secretion, ET aspirate. It is good to know what is grown, because whatever is colonized or whatever numbers, if you don't get this 10 power 5, if it is less than that, it is good to know, because uh, you know that these organisms have already started colonizing there. At any point of time they may go into invasion and cause actual infection. So the moment the colonization happens, or you get to know, better to talk to the clinician and see if the ET, that the tube can come out. Is the patient really requiring ventilation, mechanical ventilation, or not? Okay, so those things are um, that should be kept in mind. You have to talk to the clinician before you release the report. So what do we how do we record these? VAP rate, number of VAPs that has happened over number of ventilated days into 1,000. That is a traditional way of calculating things. These even VAP has that SIR, okay, standardized infection ratio and all that. I have not repeated in the slides because that is one common thing that we have to shift over. If you look at it, even NABH recently they are asking for SIR, okay, not the actual VAP rates. Okay, we are also turning to that stage wherein we are going to record it kind of a uniform all over the country and trying to get out some expected VAP rates or in HA rates. Okay, now how do we prevent these infections? Of course, first is the training on how to, is a tube really required or not? Daily assessment of weaning. Try to wean and see if the patient can tolerate or not. Okay, so this has to be done actively. That is one thing which I want to stress here. Every day there has to be an assessment whether the endotracheal tube is required or not, and see if the patient can withstand or the weaning part of it. Okay, like catheter care bundle, you have endotracheal tube care bundle also. Of course, hand hygiene is always there, which has to be stressed and which helps in prevention of VAP. Okay, where am I? Yes, here. Okay, so the only thing is, like, I have not changed the cases because it will be too stressful and too confusing. So I've maintained the same case for most of the infections to describe here. So the same case, the first case that we saw, a patient with stroke, after some days, the same patient continues to have fever. Fever is still there, not gone. Now this time, what has happened? Hypotension is present. Okay, so what they did, the intensivist puts up a central line for addressing, administering drugs. So central line is put. Blood culture sent. Okay, reported as Enterococcus species isolated. Following this, intensivist realizes he had to identify if central line was a source of infection. He sends one sample collected from the line and another from peripheral vena puncture. Okay, is it correct? So there was Enterococcus species which was isolated in the blood, and the intensivist has sent two samples, one from central line, one from, okay. Okay. Yes, all of you say that it is right. Fine. So the first point is we want to know where this enterococcus is present and where did the enterococcus come from. There are two questions that has to be answered. So first is where is it present? Is it seen? Is it colonized the central line? Is it that is the central line the source of infection for this bloodstream infection here? So he has sent two samples. Now coming to bloodstream infections. Okay. Bloodstream infection, if you see the guideline, it almost runs to 100 pages. Okay. So it's a huge document. They describe so many different types of bloodstream infections. It's one of the most extensive, I would say, information that is given in this guideline. I think all of us or all of you also should read this guideline. It not only addresses the central line related bloodstream infections, even beyond that, it goes beyond that also. Okay. So there is something called laboratory confirmed bloodstream infection. There is clinical bloodstream infection, clinically diagnosed bloodstream infection. So those are those which we report from the lab as some organism grown with susceptibility. Report that is what is called laboratory confirmed bloodstream infection, where most of the times we give no growth from the blood culture bottle. Those are not lab confirmed. It is mostly clinically diagnosed bloodstream infection. Okay. So for a laboratory confirmed bloodstream infection, okay, there are some criteria that you have to look for. It's not so easy as SCOTY or VAP or something. This bloodstream infection is a whole lot of things that you have to look for. Okay. There is something called eligible BSI organism. Okay. Means to say, not all organisms in the blood are important. Just to put it as a plain sentence like that. Okay, some organisms, though isolated from blood, we don't give much importance to that. We just ignore saying that it can be contaminant, it can be commensal, like that. So there is a list of organisms which are called eligible BSI organisms. So there's a list available in the same guideline, and you have to have that list, and only those organisms which are there in that list can be reported, even if it is even if it is from one blood culture bottle. Okay. Then eligible central line. Okay, that is the next word that or phrase that you have to look for. When we say eligible central line, the the venous catheter should go in one of those big arteries or veins. Okay, that is considered to be central line. Okay, that is eligible central line. Peripherally inserted, central lines, catheters, all that also will be considered, but then the tip of the catheter, or at least some part of the catheter, should be in one of those big vessels, large vessels. So then only you can call it eligible central line. So what does this LCBI-1 say? Recognized bacterial fungal pathogen not included on NHSN common commensal list. Okay, so this NHSN guidelines has eligible BSI organism, has common commensal list also. Okay, so we can refer to that and then do a good reporting. Okay, so they have classified them as those organisms isolated from one or more blood culture bottles also. Okay, so it is easier to report. Organisms identified in blood is not related to an infection at another site. Okay, the person is having some kind of wound infection, some other organism has been isolated, but blood is a different organism. So those kind of uh, that criteria. Okay, then what is there is something called MBI. This is one thing that most of us ignore or do not know about this. MBI is mucosal barrier injury. Okay, this is the intestinal organism, okay, which comes into the blood because of some break or breach in that mucosa of the intestine. Where do we see this? Textbook, or traditionally we say that in graft versus host disease, in diarrhea or neutropenia, this is possible. But then practically, or when you're working in a hospital where which caters to say a lot of malignancies, transplants and all that, the mucosal barrier injury is very common. People who are administered anti-cancer drugs, though it is IV, there is a mucosal barrier injury in that case. Okay, so there are so many drugs, medicines which are taken orally, which can cause mucosal barrier injury. So that becomes a source of infection. I think most of us, or most of you will agree that the commonest organism that we report in blood culture is E. coli, other than cons. Yes, so cons, of course, it is from the skin, but then if you look at it, the intestinal organism, like what is said here, E. coli, Klebsiella, all these things come up in the blood, and we'll be wondering whether to report, not to report. Okay, even if you report, I think it is always better to go back and ask the history of the patient before you report, because you will know whether there is mucosal barrier injury or not. If there is an injury, then definitely there's a possibility that the organism has come into the blood. If there is no possibility of mucosal barrier injury, then it has to be taken with a pinch of salt, because E. coli is not seen so easily in the blood, or intestinal organism does not come into the blood so easily. Okay, so that is about LCBI 1. Now, what is LCBI 2? Okay, then the patient has at least one of the following. There is fever, chills, or hypotension. Like our patient also had fever, started with fever, then hypotension also was there. That's why the central line was put. Organisms identified in the blood is not related to the infection at another site. Why this sentence is repeated on and off is that there is something called primary bacteremia and secondary bacteremia. Okay, when we are looking at bloodstream infections, we are talking about primary bacteremia. Means to say that the organism is causing, or it's present in the blood, multiplying, and the signs and symptoms are related to the organism being present in the blood. But there are some cases where you have secondary bacteremia, wherein the patient is having wound infection or respiratory tract infection, pneumonia is there, and the organisms spill out from that particular site or the organism into the blood. Okay, so those are considered to be secondary bacteremia, and they are secondary BSI. They are not primary bloodstream infections. Okay, so if an organism has been identified in the blood, which is the same as the another site, then it is not considered to be primary bloodstream infection. So that is why the statement organism identified in the blood is not related to the infection at another site. Common commensal is identified by culture from 2 or more blood specimens collected on separate occasions. Okay, this I think most of us know, that any skin commensal or something like that comes up, we need 2 or more blood specimens to report on that. Take care that the blood sample collection also should be separate, not at the same point of time. Again here, intestinal organism, if present, look for mucosal barrier injury, and which is commonly seen in GVH, diarrhea, and neutropenia patients. So that is about the bloodstream infections. Actually, if you look at it, hardly I have put some 2 slides or 3 slides, which actually does not justify the entire 120 page document. But it is so exhaustive, so much of information is there that I cannot cover it in such short time. So that is why I have not included many things. It's very interesting to read. I think I would tell everyone to have a look at it. And if you have any doubts, we can always discuss. The last infection that we are going to discuss is about surgical site infection. Here, most of us know what is the surgery, what is a surgical site infection. What we have to remember is there is something called superficial, incisional. There are the classification, that you have to remember. The superficial incisional SSIs are monitored. I mean, they can be that, they can be deep wound infections, even the organ underneath can get infected. So they are the different stages of SSIs or different types of SSIs that we can come across. So what is an SSI? The surgery. I mean, when we take surgical site infection, what is the surgery that we're talking about? It should have at least one incision, okay, which can be even laparoscopic approach, cranial burr hole, all that is included in this category of surgery. It should be made through the skin or mucous membrane. Entry is through an existing incision, or entry through an existing incision means to say that suppose there was a prior surgery and repeat surgery, also that is also comes under the same category. This procedure has to take place in an operating room. If there is a C-section room separately, then that one. Interventional radiology room also, cardiac catheterization lab. See, all these things are considered to be OT or surgery areas. Superficial incisional SSI are monitored for 30-day period. 4 wound classifications are available within this NHSN guideline. That is clean, clean contaminated, contaminated, dirty, or infected. Okay, these are the categories that are available. For each category, there are sub guidelines that they can call it. And they have given what all surgeries are considered to be clean, what is clean contaminated, what is contaminated, all that they have described so very extensively in this guideline. The only thing is they have used a lot of short forms. Of course, you have to go into the document to see the actual expansion of these short forms, the codes basically. APPY is appendicectomy, then cholecystectomy is DILI, something like that. Closed, you have laparoscopic, or you have open, all that categories. Okay. Now, just a few words about each category. Superficial incisional SSI, it happens within 30 days of the operative procedure, where day 1 is taken as the procedure date. Okay, if the surgery happens today, today is day 1. It involves only the skin and subcutaneous tissue of the incision. The patient has to at least have one of the following, that is purulent drainage from superficial incision, organism identified from aseptically obtained specimen from superficial incision or subcutaneous tissue by a culture or non-culture test done for diagnosis. Okay, so non-culture tests are those PCRs and those tests. Okay, here what you have to remember, okay, when doing RCA or during the discussion, you have to see in the case sheet whether the attending surgeon or the intern doctor, PG, whoever it is, resident, has written this word purulent drainage. Has he seen pus in the tissue or the incision site? Okay, that is most important. If that is there, then only you can consider that it is superficial incisional SSI. Then of course you will have the culture report, yes, that you can uh, take into consideration. Superficial incision that is deliberately opened by the surgeon or physician for pain or discharge. Okay, the surgeon or the physician who decides that yes, this incision should be opened for discharge, to look for pus. Okay, in that situation also is taken as one of the criteria. Yes, these are some things which we have to look into. Treatment of cellulitis, diagnosis or treatment of cellulitis, like there is no cut or anything, right? Redness, warmth, swelling by itself does not meet superficial incisional criteria. So just redness, warmth, swelling does not qualify for SSI criteria. Please be aware of this, because most of the time if they see redness or swelling, they just write SSI and then leave it at that. So you will be over reporting on SSI. Look at it that there should be a purulent discharge. Okay, unless and until there's a purulent discharge, SSI cannot be diagnosed. A stitch abscess alone, minimal inflammation and discharge confined to the points of suture penetration. That is also not considered to be SSI. A localized stab wound or pin site infection, depending on the depth, these infections might be considered either a skin or soft tissue infection. Okay, again, it is not SSI. These come under the orthopedics department where they use Elizaro. Okay, so the pin tract, pin site infections, depending on the depth, you have to see whether it is skin or soft tissue infections. It's not SSI. Deep incisional SSI. Okay, here the underlying organ, all that is involved. This can happen with an interval of 30 to 90 days between that period. It involves deep soft tissues of the incision, fascia, muscles, all that are involved. There can be an abscess or other evidence of infection involving deep incision detected on gross anatomical examination. Means to say the surgeon reoperates or reopens the site. Okay, it can be diagnosed by histopathological examination or imaging test also. So that is about the deep incisional SSI. So that completes our discussion on common HAI. If you have any questions, I think I can take that now. Shall I make this be on? Are you going to put it in the chat box?
Good evening, Sandeep. Can
Yes,
you hear
sir.
me?
Yes, sir.
Yes. Nice discussion put up in a very simplest possible manner for understanding of the postgraduates. Now, the topic is open for discussion. Anybody wish to ask any queries, want to add up, you are welcome.
Yes, documents. Yes, I will share it with the organizers. I think they can share it in the group.
Definitely, the recording of this session definitely will be shared with all the participants into various groups, because we don't know the personally the participants. It will be shared in various WhatsApp groups, and anybody can anybody and everybody will have access to the recordings of this session.
What I would suggest is my personal experience with this HAI and RCAs are none of us can remember all the criteria. Okay, always. So it's always better to carry that guideline whenever you go for an RCA and open it up at that point of time to decide whether there is, actual SSI or HAI or whatever. Okay. But yes, of course, for PGs, I think you need to know at least a little bit for you to write in the exam. I wouldn't say by heart everything, but then, yeah, basics are. Okay, I'm just looking at the questions. Quantitative culture for ET secretions. Yes, this is something like it's not, I wouldn't put it as quantitative, it's semi-quantitative, like what we do for urine cultures, the same way that we follow for ET secretions also. So if the whole plate is there, whole lot of organisms, then yes, 10 power 5, and so the interpretation is similar to urine semi-quantitative culture. In traditional method of calculating COT-TVAP rates, how the denominator is calculated? Yes, this is a big question. Okay. So you have to capture the data of how many patients are admitted, how many patients are having, that device, catheters, and how many days. Every day the ICN or the nurse has to record. Okay, today 20 patients are there in this ward or ICU. Of them, 5 patients have catheters, 3 patients are on ventilator, like that. Every day it is recorded. And finally, in that, then the numbers are added to find out catheter days or ventilated days, and then for a month or so, and then the numerator, that's how the denominator is calculated. It's a little tedious process. I think once you get into that routine, then you will get to know that. Significance of MR cons in blood. Okay, whether it is MR or MS or whatever, it is cons is cons. We don't give much importance to coagulase negative staphylococcus in blood culture. If it is from, yes, single blood culture, there are very specific diseases or infections where cons is given importance, like infective endocarditis with a specific risk factor, of cons endocarditis. Okay, in such cases we give importance to that. Otherwise, cons is generally taken as skin commensals. What is protected specimen brushing? Okay, this is a question for pulmonologist. Anyway, whatever little I know, I will tell you. The I think all of us have seen a bottle cleaning brush. Okay, just imagine that is a very miniature size of that. Okay, and there is a tube that is put into the bronchus or the bronchiole, and then this uh, brush is inserted, and then specimen is taken. While removing it, the brush is pulled into the sleeve, and then the entire tube is taken out. The purpose is that the brushing or the brush has touched only the inner surface of the distant bronchus or the bronchiole. So we are taking kind of a lower respiratory tract specimen. While taking it out, it is not touching the trachea or the oral cavity. So that is a protected brush specimen. Okay, then how much time gap should be there between peripheral blood sample and central line tip to call it as lab C? Okay. This is logical. We just take, of course, 2 hours is the what is the standard time that is taken. So central tip, central tip. It's not central tip. Central line sample. Okay, blood from central line beeps 2 hours earlier to peripheral blood sample, peripheral vena puncture that is taken as um, probably CLABC. Yeah. So if you have to decide on this, you have to record the time when the central line sample has beeped positive. Then you have to record the time when the peripheral line has beeped positive. Okay. Yes, let's stop using cons. We'll do that. Yes, sir. Taken, sir. Let's start using it as SOSA. Yes, SOSA.
Staphylococcus other than Staph aureus.
Yes, okay.
That is the latest, because we have to get used to that terminology, especially PG students in their exams. Using the word as Staphylococcus other than Staph aureus gives a better impression for the examiners. That means the PGs, when you say SOSA, the impression the examiner gets regarding the PG students is totally different. Okay. What is protected specimen brushing? Answer that.
Yeah, I answered that. It's a small tube that is put into the
I
bronchus.
was busy with something else. Okay.
There's some bottle brush kind of a thing is there, which is taken. That's what I know about it. I think pulmonology people would be a better people to answer that. But the essence or the concept that in that is like the brush does not touch the upper respiratory tract. It just goes inside, and the sample is taken from the lower respiratory tract. Jayanti madam, thank you
Jayanti
so
madam,
much.
madam, can you please give a call? Madam, you can unmute yourself, madam.
Thank you for all the doctors who have thanked me. I'm thanking you back.
Uh, Thank you so much, Doctor. It was a wonderful talk, very informative, and I hope the PGs, paid so much attention to whatever you were saying.
Thank you, ma'am.
Thank you. It was really very informative, and most of the things we do follow in the hospital, but then like you rightly said, calculating those rates is the biggest
Yes,
nightmare.
ma'am. Yes, yes.
Yeah, but otherwise, because the rest of the things are under our control in the lab, we can still do it.
Correct, ma'am. Correct.
But
Yeah.
getting people to do the rate calculation is what
Rate
something I think
calculation
all of us
is.
have to,
Mm.
insist on for us to realistically have a data.
Correct,
Otherwise,
ma'am.
it becomes a little difficult and tricky.
But
Thank you
it's a
so
good
much.
start off, ma'am. That's what I would put it as, so that we'll have a national average,
Sure.
national expected rates and all that. It would be good.
Good. At least I think the tertiary care center should start looking at it
Yeah.
critically.
True.
Yeah. Thank you. Thank you so much. It was really wonderful listening to you.
Thank you,
Yeah.
ma'am. Thank you, ma'am.
Yeah.
And
Bye.
before we conclude, before I say thanks to Sandeep, I would like to tell all the participants that this IAMM-KC Masterclass is an initiative from IAMM Karnataka chapter, and we want to remind all the participants that it will be a continuous teaching program. I don't want to call it as a teaching program, because it is a mutual learning and teaching and learning experience, because we also, each one of us will learn every day, and it is fixed every second Friday and fourth Friday, 6 p.m. So I request all the participants to mark it in their calendars. So there will be as much as possible, we don't try to alter any schedule. It will be second Friday and fourth Friday of every month, so that you will be keep yourself mentally prepared and keep yourself mentally free, so that the schedule is fixed, so that every PG will be have a that fixed schedule. Every second Friday and fourth Friday, they can be prepared for this IAMM-KC PG masterclass. And we hope that we try to get the best possible topics with the best possible speakers to help you all. And we expect more and more participation for this IAMM-KC PG. And the participants are also free to give up their topics of their interest. We will be happy to take up those topics for the upcoming sessions. Anything is there, you can put up a message to IAMM-KC, or any of the, you are getting the invite to various WhatsApp group, you can put up to any of us, we will take up those topics. So that is our message to all the participants. And I don't know how to thank Sandeep. Sandeep, I had been listening to, and every time I have any doubts, I keep talking to Sandeep about HAI and other ID related issues. Thank you, Sandeep, for your wonderful.
Thank you, sir. Thank you for giving me this opportunity.
And you have made it in a most simplest possible manner, the most easiest. It was no complicated words, no complicated things, simplest possible manner. Thank you very much. We hope to keep learning. We'll keep bring you again and again for more such.
Yes, sir. Yes, sir.
Thank you.
I'm willing to get troubled for such reasons. Thank you, sir. Thank you so
Thank
much.
you.
Thank you for
This
Satyanarayana sir
recording will
also.
be stopped and it will be shared with everyone. Thank you. Thank you for everyone for your active participation. Thank you.